Hello there, and welcome back. Today we're going to be talking about healthcare and whether privatising healthcare or increasing market competition is a possible solution to delivering affordable healthcare. If you hadn't already realised, I'm British, specifically from the best part of Britain, the land of Sean Bean. As a consequence, for most of my life, I've had healthcare covered by the National Health Service, and so have rarely, if ever, had to worry about the cost of healthcare. This is, of course, for you American listeners, a rather different experience. What I'd like to do first is talk about what healthcare actually is. Then we'll look at the common myths around the public option before discussing what makes a system successful. The timestamps are in the description. Public healthcare became an issue in most of Europe towards the end of the 19th century. Prior to this, it was a patchwork of monastic hospitals and charitable organisations. The wealthy often had a sense of social obligation to fund these endeavours. However, as we see today, charity is an unreliable source of funding, and this meant that the nascent patchwork of hospitals was always under pressure because of a severe lack of funding. Then, as now, charity often came with conditions that also restricted evidence-based healthcare. As political participation and the drive to mass enfranchisement began to gather pace towards the latter half of the 19th century, solving the lack of healthcare became a political issue. Otto von Bismarck, the Iron Chancellor, created the first public health system of the modern era with an insurance-based system in 1883. Britain followed suit in 1911 with David Lloyd George's National Insurance Act, which provided for primary care but nothing beyond that. The Russian Empire followed in 1912, and by the 1930s, virtually all of Europe and the major powers had some form of public healthcare. The Soviet Union put in place full universal healthcare in 1920, but as with many political reforms, rural communities were not covered at all in practicality, and so experts debate whether you can truly call this universal healthcare. Following World War II and the devastation of that war, public health systems sprung up around the world, with the dividing line being a public insurance system in the vein of France and Germany, or the beverage system as adopted by Britain and the Nordic countries. Both systems have their advantages and their drawbacks, but both are committed to the principle that all citizens within the nation will have access to healthcare whenever they need it. The idea of people suffering out of need of a doctor but being unable to afford one was seen as something that needed to be consigned to the past. Of course, the elephant in the room is the United States, who have, let's say, a less than stellar reputation with public healthcare. In all seriousness, this model is based on private insurance, often but not always through the employer. This is quite similar to Bismarck's model from the 1880s, and it stems from hostility from the medical profession, a deep sense of individualism, and distrust of the federal government. All real attempts at reforming US healthcare have resulted in abject failure. It was seriously spoken on the agenda of President Kennedy, as you can see here.
The fact of the matter is that what we are now talking about doing, most of the countries of Europe did years ago. The British did it 30 years ago. We are behind every country pretty nearly in Europe in this matter of medical care for our citizens. And then those who say that this should be left to private effort. In those hospitals in New Jersey where the doctors said they wouldn't treat anyone, who paid their hospital bills through Social Security, those hospitals and every other new hospital, the American people, all of us, contribute 1/2, 1 or 2/3 for every new hospital, the national government. We pay 55% of all the research done. We help young men become doctors.
And successive presidents and congresses have failed to do anything truly meaningful in terms of systemic reform. The closest was Obamacare, but in a perhaps naive spirit of bipartisanship, it was watered down into an ineffectual mess. So let's define some terms. Privatised healthcare, or free market insurance, is where the individual or an employer, as part of an individual's employment, pays a monthly or yearly insurance premium for that person's healthcare. Some things are covered, some things are not. It is at the discretion of the insurance, which operates on free market principles with varying degrees of legislation and oversight. Single-payer insurance is where, instead of a marketplace of insurance companies, a single, publicly owned and ran system covers the insurance to private hospitals and doctors. The government does not run the healthcare system. It simply acts as the intermediary to collectively bargain the cost. This is what Canada has. It does not preclude private health insurance on top of the government single payer. Socialised medicine is where the government runs not only the public insurance through direct taxation, but also runs the hospitals. Private healthcare can exist and often does, but this is completely separate from the National Health Service, which is available to all free at the point of use. This is what Britain and the Nordic countries have. You get many combination systems, where they are part socialised, part single payer, or perhaps part socialised, part insurance such as Singapore, or even non-profit sickness funds such as in Germany. There is a lot of diversity out there, and evaluating which model is best is fraught with difficulty of statistical analysis and even just how countries report their healthcare system. It's also impossible to simply transplant a healthcare system into another country. Despite the same principles underpinning UK and Nordic healthcare, they are expressed in different ways. It wouldn't be possible to simply copy and paste the NHS from Britain into the United States. It's a non-starter. So let's talk about myths around public healthcare. 6 or so years ago, I was having a conversation with a friend of a friend. This acquaintance was from Georgia in the United States, and he'd sent me a documentary from John Stossel about healthcare in the United Kingdom. I watched it and let's say I was not amused, because it was full of factual inaccuracies. Indeed, most of the conversation around healthcare in the United States is filled with misconceptions, myths and inaccuracies. These myths and inaccuracies have often spread around the globe because of the influence of American culture. Let's start with the biggest one, the cost. At every turn, the commentators on the right and those that decry universal healthcare or even single-payer healthcare do so for being hugely expensive, that it will put up taxes and in the grand scheme of things cost more for the individual than private insurance. There's two parts to this myth, that it will put up taxes and that it will cost more than private insurance. Let's get this out of the way early. It will put up taxes, there is no doubt about that, because it is paid for through direct taxation. There is no insurance. The taxation replaces insurance entirely, and that cost is far, far lower than private insurance. Almost every piece of data imaginable demonstrates clearly single payer is about half the cost of the United States private insurance scheme with superior outcomes. Studies conducted in 2010 and 13 ranked Britain's NHS and France's healthcare system as having some of the best outcomes in the world for under half the cost as a percentage of GDP. So in terms of cost, it's not nearly as expensive as you might think. National insurance contributions are for most people below 2% of their monthly salary, which is far, far lower than what you pay on private insurance. And bear in mind that this 2% of this monthly salary covers all healthcare. You will never be billed for a copay or cost exceeding bans or anything like that. The prescription rates are fixed at relatively affordable rates too, if the government chooses to charge for prescriptions. The result of this is a net saving to the individual and family. The average US household will be paying around $600 per month in premiums. Just going off a basic understanding of the data, this will change to $300 per month for single payer with zero additional costs. You will never be charged copays and deductions. They don't exist. You will never go bankrupt because you've lost your job because you have cancer. In a single payer system, Walter White never becomes Heisenberg. He simply gets the healthcare he needs, as does Walt Jr. and everyone else. The second myth is on rationing or death panels, as Fox News love to scream over Obamacare. I find this to be rather bizarre. Even when the NHS struggled, we've never had a situation where we're rationing healthcare. Not even in the aftermath of World War II, when everything was scarce and the NHS was new, was rationing a thing. I understand the weird logic of it. If you make it available to everyone, you increase demand. But that's counteracted by the economy of scale. When it comes to healthcare, the government, contrary to many people's opinions, are far, far more efficient than the private market because of the lack of profit incentive. The creation of a holistic system increases efficiency. And bear in mind that the measure by which rationing can be measured is the mortality amenable to care. That is someone who could have been saved if they receive care. Britain, with socialised, government-run healthcare, is demonstrably lower per 100,000, so the idea that rationing somehow increases under socialised or even single-payer healthcare just isn't true. If anything, it decreases because of that increased efficiency. The third myth I'd like to address is that it creates a massive bureaucracy. Well, it already exists in US healthcare. If anything, it's even bigger than socialised medicine or single-payer systems. You not only have the individual hospitals, each with their own bureaucracies, but then you've got the insurance companies, each with their own bureaucracies, who each have their own standards, and so on. That lack of standardisation and easily transferable data causes a massive amount of bureaucratic headache, especially when you have to have an itemised billing service. If anything, single-payer systems trim this bureaucracy down massively because you no longer have the billing service to account for. The fourth big myth is that private insurance or private healthcare is prohibited. I could just say that in Britain we've got a lot of private hospitals and care, such as Bupa, and considering we've got socialised medicine, that should prove this untrue. But let's look a little deeper. The idea that you can't have private healthcare inside a socialised system or single-payer system stems from the idea that because the government provides, nobody is able to choose elsewhere, which isn't the case. The government provides for everyone, but there is no obligation to use it. Many wealthy individuals have their own private cover, and some of the more high-paying jobs include private healthcare as a provided benefit. All having a single-payer or universal system means is that everybody in the country is covered by default. If you wish to pay for a private scheme, nothing and no one beyond your own circumstances will stop you. Another big myth is about wait times, that people are waiting endlessly for critical and necessary procedures. This has differing levels to it. If someone needed urgent care, under most universal and single-payer systems, they're seen almost immediately. Where the systems get into trouble is non-urgent specialist surgery, where there are often shortages of qualified staff in universal and single-payer systems. This is not something that the US suffers from, mostly because so many people are uninsured or cannot afford non-urgent care that they will wait until it becomes urgent. This is of course a problem. People having to wait for care is not a good idea because conditions can worsen, quality of life worsens, and generally, the longer you wait, the harder the fix. However, in a public system, this simply requires the political will to change things, whereas in the US's private model, this is a built-in feature because of the cost of the uninsured. The sixth myth I'd like to address is that of quality, that universal care or single-payer systems somehow have lower quality healthcare than the United States. They often point at the finest point of care received by the wealthiest people as an example for how the United States is a world leader. But this is the thing, the finest quality of care available for the people with the most money is broadly the same across the globe and definitely in the wealthiest nations. When it comes to the level of care received by the average person in the United States, well, in almost every form of analysis, the United States comes bottom in the comparison with other nations. One of the few areas it doesn't is cancer detection, and that is because of a well-noted tendency of the United States to order unnecessary tests. And care that the average person will receive, private systems tend to lag behind because the expense is prohibitive for the average person. In real terms, this means that universal and single-payer systems vastly outperform privatized insurance-based systems in almost every level, and crucially, people don't wait for medical issues to develop to the point of an emergency because of a need to justify the cost. One myth that people often like to tout is that medical research and innovation is higher in a private system than in a public one, which isn't necessarily the case. As with Viagra and pharmaceutical companies, the incentive to innovate isn't really there with healthcare. Such is the cost and burden of making sure that these new innovations or inventions don't kill. As with the vaccine drive, it is often through state-funded and directed research that these innovations and inventions are made. Synthetic insulin, for example, was invented in publicly owned Canadian laboratories. We also have to bear in mind that the ethical dilemma here, this devil's choice, is the physical and mental well-being of millions of people versus an invention or innovation that eventually may help them decades down the line. That isn't an equivalent or fair or even a just exchange. Another point I've heard deployed against single-payer and socialised systems is that it reduces wages for medical professionals. Considering that healthcare workers in the United Kingdom are amongst the top paid people in the country, often at double the average wage, I'd consign this to the rubbish heap where it belongs. Most of the issues around universal healthcare stems from training enough doctors and nurses rather than paying them attractive wages. I've seen a rather bizarre suggestion that Americans won't work if they get universal healthcare because their insurance is no longer tied to their jobs. I do wonder if they're aware that most of the developed countries on the planet have some form of public healthcare and have high employment rates. Indeed, it is likely to have the opposite, in that Americans leave bad jobs and move into better ones once they've got their healthcare. It increases worker mobility, and going back to that point about savings, it's likely to act as a stimulus, which leads to more economic growth because people will now be able to buy that car or that house instead of being burdened by unfair insurance payments. I've also seen it suggested that universal healthcare makes it easier for people to want to be obese or something like that, because other people will be paying for the bill. This is frankly untrue, with the causes of obesity being nuanced, but being heavily linked to the content of food that is consumed rather than just its volume. The United States has private healthcare, and yet has the most obesity in the world, so clearly universal healthcare isn't causing that problem. Moving on from myths, let's talk about Singapore. The right wing loves to talk about Singapore, as if somehow you can transplant Singapore's health system into the US and make it work, not realising Singapore is really not the healthcare system they think it is. Nearly always, we only ever hear about the market side of Singapore's success and not the costs or the role of government in Singapore. In Singapore, there is almost the inverse situation to the single-payer model, in that instead of the government running insurance and the market running hospitals, the government runs the medical facilities and the market sort of handles insurance. And bear in mind that the government forces everyone to put 7 to 9.5% of their monthly pay into a government scheme that operates as its own form of insurance called Medisave. You are not allowed to withdraw funds from this account except for approved forms of healthcare and pharmaceuticals. This is intended to pay for any primary, non-emergency, low-level care that a person may need. The second plank of Singapore's health system is MediShield Life, which is the state-run insurance scheme. This kicks in for all large bills and has a copay and deductible which must be met before it kicks in. There is a maximum claim per year, but not over the lifetime. Enrollment is mandatory. MediShield Life is integrated within private insurance plans to try to provide maximum coverage for the cheapest price possible. This is through cooperation between the market and the government. This, combined with Medisave, in theory, should cover all costs that the average Singaporean citizen will incur on medical care. Naturally, there is a third program for Singaporeans who cannot afford medical costs, with both previous programs. This is called MediFund, which is only available to citizens who are either in extreme poverty or have exhausted their Medisave and MediShield funds. MediFund is not an unlimited supply of money. There is a hard limit on how much is spent per patient per year. This can expose individuals to catastrophic costs in catastrophic medical emergencies. The Singaporean government often tops up this fund in years of budget surpluses. In addition to this, there are also numerous subsidies paid out to individuals such as single mothers or the elderly who are unable to work and provide the funds necessary to properly take advantage of Singapore's healthcare market. So let's evaluate this, shall we? The most important thing to realise here is that Singapore's healthcare works, and it does work not because of market forces, it's because of Singapore's aggressively controlling government. Singapore has a technocratic, authoritarian government that focuses on utility, which is a far cry from the liberty first, market will decide approach that many on the right believe Singapore adopts. It aggressively controls costs through collective bargaining of pharmaceuticals, and it expects that every single insurance company will act responsibly and not try to maximise profit. Yes, you heard that correctly. The Singaporean government mandates that health insurance companies will not seek to extract maximum profit from their activities. Germany too seeks to remove the profit incentive by running their healthcare system through non-profit organisations. Sensing a theme? The market is strictly controlled, regulated and put to work for the state. There is a very front-footed approach, and the state does not allow deviation from this agreement and will crack down very hard on what they consider profiteering activities. This is a far cry from the free market approach of the United States and indeed what many conservatives in Britain argue for. In fact, the best medium for determining whether market influence is a good idea or not is, funnily enough, Britain. Britain has one of the most socialised forms of healthcare on the planet after the creation of the NHS. Most people in Britain have never worried about healthcare for exactly this reason. During the 1980s, Margaret Thatcher's Conservative government severely underfunded the NHS, which led the Labour Party to rapidly increase funding in 1997 and use the misguided private finance initiative to try and improve outcomes. The result of this decade of Labour governance was an NHS that by 2010 was seen as one of the finest healthcare systems on the planet. David Cameron, the Conservative Prime Minister, famously promised no top-down reorganisation of the NHS, and then promptly did that with a series of reforms through the early 2010s to try and increase market forces within the NHS. These reforms have all been focused around privatising services and increasing market competition. The result of this has been the first strike in NHS history, declining outcomes, declining patient satisfaction, increased wait times, increasing costs, and a general sense of malaise around the service. Indeed, one of the reasons that the NHS has struggled so much with COVID has been because of this continual privatisation drive by the Conservative Party. Almost every single one of those problems can be directly traced to attempting to increase market competition in a system that was already running amongst the best in the world without it. It's often a joke that Brits have bad teeth, and this stems from the fact that dentistry is partially privatised. It's means tested on the NHS, and there are few NHS dentists around, and they're always horrifically oversubscribed. Between these two examples, it's pretty obvious that increasing market forces damages equal and good delivery of care. Britain has traditionally operated along the beverage model, which is also what the Nordic countries have too. That government of the people and by the people and for the people should ensure that healthcare is provided for all within its borders because having good health is a human right. In practical terms, this results in a system where the primary care in hospitals and other specialist facilities are handled by public employees. First call physicians, family doctors as they're called in the US, are however contractors who run their own surgeries and in effect compete with each other over coverage in areas. However, there are no costs, and most people in Britain will, as I have said, never see a medical bill. Indeed, even when I was living in Germany, the only time I saw a medical bill was when it was being charged to my European health insurance card, rest in peace, which was covered by the NHS. I received care on the same day for a semi-emergency condition, and I imagine if I were to fall sick in France, the same would occur. If anything, almost all the most successful systems, whether they are single payer, socialised or part mixed, all display the same hallmarks: a commitment from the government to provide their citizens with affordable healthcare with the principle that nobody should be left without cover. How aggressive the government is in ensuring those aims helps determine how successful a system can be. From Singapore to Germany, to Norway to Britain to Canada, the principle is clear, the commitment is clear. Fundamentally, what must be realised about healthcare is that the most efficient form of delivery seems to be one of socialisation, that the government providing both insurance and care tends to result in the best outcomes when the government has the incentive to ensure good care. Even in Singapore, the government provides the care. Where systems tend to fall foul is when they start to introduce the profit motive within market systems, as this tends to result in profiteering and cutting corners because of the prohibitively expensive cost of healthcare. What this translates to is a genuine commitment to improve healthcare on an evidentiary basis and not on a political one, as so often the conversation becomes around the introduction or continuation of market forces inside healthcare systems. Thank you for listening. I'm always happy to continue this conversation on my Discord server. A link is in the comments. I hope you all enjoyed this discussion, and remember to share and subscribe. These are my thoughts. What are yours? I'll see you next week. Thank you and goodbye.